Hi folks, I'm Dr. Tom Meade. Welcome to a special edition of the Dr. Meade Show here at the Mohegun Sun in Wilkes-Barre, Pennsylvania. This is special for me for two reasons. I've actually grown up here, just a few miles from here, and this was nothing more than woods where we used to drive our dirt bikes behind Pocono Downs. The second reason is I get to introduce my high-performance team. This is the reason in front of me that we could do 3 to 4 times the amount of knee surgery as the average orthopedic surgical team in the country. But with that volume, we have the highest patient satisfaction, the lowest complication, the best outcome, and the lowest infection rates in the state. Without this team, I wouldn't be able to do that. So real briefly, let me introduce this all-star team from left to right. Tom Witter, an experienced PA who's been practicing medicine as long as I have. Tom, I won't give the exact date, but I know it was in the 80s. R.J. Ritchie, a PA, he's been on our knee all-star team since he's arrived 5 years ago. Michael Joyce, one of the best surgical first assistants I've ever come across. The guy has great hands, he's a great thinker, he's a great tinkerer. He goes home to his garage, comes home with new instruments made out of soap and solder. And then we have Molly Wookich. Molly is the glue that keeps this whole team together. We operate 60% of the time. So when we're in the OR, somebody has to answer all your questions, all the pre-op concerns, post-operative concerns, and yes, occasionally a complication. Molly is there for you. Carol Matrazzo, I call her the magician of the Northeast. She is responsible for the biggest growth of coordinated health north of the Lehigh Tunnel. She's opened the Lehighton office, the Hazleton office, and yes, soon to come, the Wyoming Valley office. I don't think Carol sleeps. She is all over, and she's really a miracle worker. Pam Corey. The reason Pam is here is to solve a problem. A couple of years ago when there was a crisis, Vioxx and Bextra, remember those drugs? They're not on the market anymore. That's because too many people died. And right away, we realized that the pharmaceutical companies are not always our friends. So Pam is here to help us produce a holistic approach to medicine. Get you off medications when you can. Look at a holistic approach, nutraceuticals, and one of the prime anti-inflammatories from the natural market is omega-3 fish oil. Pam's an expert at that, and she helps all our patients pre- and post-operatively. Marie Olwine, one of the best surgical nurses we've come across. She's on our road team. She is smart, she's talented, she's organized, and she keeps the boys in line. But not only that, Marie allows us to take our show on the road, and I'll tell you exactly why. So healthcare, some of the scholars and authorities in healthcare have actually looked at the best providers. They actually do the highest volume. They are more efficient. Good quality costs less. We have more accurate diagnosis, less errors, lower complication, faster recovery, and it improves satisfaction. And that's sitting right here in front of you. Healthcare in this country is broken. Or I should say the system of healthcare delivery in the United States is broken. There are high costs, there are major quality issues, there's access problems, and there's medical errors. And I'll tell you why. You probably don't know this, but I'm going to let you in on a little secret in healthcare. When we go into the operating room, and these are some of the best places in the country, we walk into the operating room in the morning, we do not know who the anesthesiologist is, who the anesthetist is, what room we're in, who used our tools last, and who's the surgical tech that's going to help us. So it's really like a mechanic walking into the garage and asking, which bay am I in today, and has no clue who's helping him, where the tools are. It decreases efficiency. And that's what we see in our system. It's why we have been driven to really control those aspects of healthcare that we control. Namely, coordinated health has developed from a musculoskeletal orthopedic program into a hospital system so that we could control this. We're not at their mercy and the whim. We don't have to start at 8 in the morning. We could start at 6 in the morning. By 8:30, when most teams are just getting started with their first case, we have 4 total knees done. But it's taken us a while to get there. Just think if you were a professional baseball pitcher and you showed up and the coach said, "Who wants to catch today?" I mean, and that's really what happens in healthcare. How good can that pitcher be when he has passed balls and errors? It will reflect poorly on him. Or Tom Brady or Peyton Manning, what if they put their hand up and said, who's going to block for me today? And then what's going to happen? He's going to have a higher percentage of sacks. He's going to have a higher percentage of interceptions. And that's really how the healthcare system works. This is how our system works. We are like a NASCAR pit crew. When surgeons from around the world come in and look at us, they don't leave saying, wow, Dr. Meade, how do you do that? I wish they would most of the time. But what they do say is, wow, how can I get a team like that? But this team was hand-selected over the years, and a lot of surgeons don't have the luxury of doing that. And we do more than just patient care. The government, the Department of Justice, makes us disclose which implant companies that we have a relationship with. I have had relationships with most of the major implant companies in the world, Stryker, J&J, DePuy, Biomet. And with them, we've spoken, we've created instruments, we have patents, and right now we're working with Arthrex to generate the next generation of implants. These are some of the instruments and the equipment that we have patents on, have helped develop or improve. You can see real quickly we have kneecap replacements, knee resurfacing. We don't have to replace the whole knee, partial knee replacements. We can do a whole total knee with the instruments on this table. Most facilities have 7 or 8 trays, so we've made everything more efficient. We've consolidated it down. The only non-knee operation I perform is clavicle fractures, and that's because we invented a plate that's lower profile that never has to be removed. So not only does my team help me do surgery, but if the average orthopedic surgeon does less than 50 total knees a year, we do more knee procedures in 1 year than some surgeons do in their whole career. It's like a working laboratory. Every case we look at what's wrong with the instruments, how can we make it more efficient, and then these implant companies select us to generate the next generation of implants. If a jumbo jet went down today, it would be on the news for a week. This is the sad secret in medicine. The equivalent of 4 jumbo jets go down every week. 1,000 people, 98,000 folks a year are killed by hospital errors. You never really hear about it. 1 in 4 patients here in the audience, if they have been in a hospital, have been subject to a medical error. Wrong side surgery occurs 40 times a week. So never get annoyed when you get into the hospital and somebody's marking your legs. Certainly orthopedics is the biggest subspecialty that is susceptible to that. 25 years, we've never had one cross our fingers. That's because we have steps in place. Every day we go through those steps to avoid these errors. If medical care were a disease, it would be the 6th leading cause of death in this country. 25% of all test medications procedures are unnecessary. What other industry misses the mark this often? Not too much. You wouldn't be in business. Competition drives innovation and quality care. You wouldn't have the iPhone 5 if there wasn't competition, but that does not occur in healthcare. We don't reward the best providers. We don't reward the best hospitals. Frankly, what happens is they go broke and they get consolidated, and you're seeing that in the Valley. Just look what's happened. You have 2 major systems that have now consolidated all the hospitals in the Valley. One is for-profit, one is not for-profit. So these old, antiquated hospitals still stay in business. If they're for-profit, they answer to Wall Street and their shareholders. And if they're not for-profit, they're just trying to stymie competition. They're eliminating competition in a health field that's needed the most. So let me just touch base on Obamacare. I thought that we cornered the market on lies and misinformation until I watched the presidential debates the other night. And I realized we don't have the market. But Obamacare, few have read it. Even Congress, it's unreadable. It's 2,600 pages. And if you think of it, our forefathers framed the Constitution in 18 pages. I think that's a lesson some of our congressmen should look at. There are winners and there are losers in the Obamacare. The insurance companies get 50 million more patients, and the newcomers to the United States get immediate care and taxpayer subsidy without waiting on these new insurance exchanges, which haven't been created, but you'll soon learn a whole lot about them. The losers, home sellers. Do you know one of the biggest investments of your life, if you've kept it well, you've improved it, and you sell it at a significant profit, well, 4% of that tax is going to go to pay for Obamacare. And seniors really get hammered. $716 billion will be slashed from Medicare and Medicare Advantage. The individual mandate, for the first time in history, we are forced to buy a product, and if not, there will be tax consequences. In a few years, it'll be between $600 and $2,500 fine. It will be taken off your refund with the goal to standardize medical practice and decrease care. Two new entitlements, a Medicaid nation. If anybody's been participating in Medicaid, it was always a temporary safety net. It was considered medical welfare. Now it will become a permanent entitlement in place of private insurance. And I can answer some questions on what doctors think of Medicaid at the question period. And we're going to have these things called state exchange subsidies. It's going to cost us $640 billion, even for families that don't need it, making $100,000. That's $1.2 trillion in a country that's going broke and depends on China. So let's summarize the Obamacare. Historically, the government looked out for the poor, the elderly with Medicaid and Medicare. The rest of America, we took care of ourselves. That's what America was about. No longer. The government now thinks that they're the best ones to take care of us. They'll borrow money. They'll use tax hikes. The federal government, which is really us, is going to pay for 50% of all the health care in America. And again, right now, if you think the health care or the government can run health care, look at the VA system. It's a safety net for VA patients and veterans, but it's certainly not where we get the best care in this country. So let's get back to the knees. Let's take a break. We're going to go over why we came here. We're going to answer some questions, some myths, and challenge some dogma out there in the knee world. And we'll be back right after this message. There's going to be $716 billion cut from Medicare. And some of the most popular operations that improve your quality of life are total knee replacement, total hip replacement, cataract surgery, and heart surgery. Knee replacement outnumbers all of those procedures. It will be a targeted procedure. And there's expected to be a 670% increase in total knee replacements over the next 15 years. And as we stated, 80% of the knee surgeries are done by surgeons that perform less than 50 a year. And our team produces better outcomes, better tracking, and better satisfaction. I have people coming in the office now because this 2,600 pages of Obamacare is out there, and they're afraid. They really don't need a knee replacement or knee surgery, but they say, I want to have it done because I'm not sure where we're going. It's not a reason to have surgery, but this is the concern out there in the general public. And there's a lot more dogma out there. You see direct-to-consumer advertising, and this is a quote by a famous Russian, "A lie told often enough becomes the truth." And that is certainly true in the world of knee surgery. You see so much in the paper about robotic surgery, computer navigation, minimally invasive surgery, quad sparing surgery. What's a replacement? What's a resurfacing? Can you do a partial replacement? Do they all do great? Can I kneel? Can I run? Can I ski? Am I too young? Am I too old? Am I going to have complications? I want the 30-year knee. I want the 40-year knee. Can I have chicken shots? What's cortisone? Is it bad for me? How many can I have? I want the high flex knee. I want the female knee. ACLs, should I have cadavers or my own tissue? CPMs. So we could go on, but these are some of the questions out there that there's a lot of misinformation. The companies know that direct-to-consumer is the way to go. So you go and ask your docs. They'll advertise something, and remember, the majority of these folks don't have the privilege of just doing one procedure. They do hips, ankles, knees. They have to do whatever they can. Because if you look at Medicaid, here's our system that's going to increase 60%. And most of the private docs out there are questioning whether they should participate. Many don't. And it's not that they don't want to. They love the people. Do you know why? Because for every $10 you provide in medical care with bandages, with time, with x-rays, with syringes,
the Medicaid pays you 82 cents. So if you're going to open up a restaurant and say, okay, what's the business model? Let me produce $10 of food, but I'm only going to charge you $8.20. You know how long you're going to be in business? Not long. So anyway, with that background, I'll throw it out to the audience, because I could talk for 2 hours on this. But any of those dogmas stick out? You have burning questions on any of those things?
Can you address what fish oil actually does? Is it positive? Is it negative? Should we be using it?
So
Thank
the
you.
answer is a great question. The answer is absolutely yes. It's probably the single best evidence-based nutraceutical I've come across in my career. And again, many of you may have noticed on CNN News in the last 2 weeks, an article came out that said, fish oil doesn't work very well, doesn't improve your life, we shouldn't be taking it. Well, you know what? So I listened to this, and if you've been around long enough, you drill down. So I drilled down on the study. It was not a study. It was somebody looked at what's called a meta-analysis. They looked at all the articles ever produced on fish oil. They didn't do their own study. And what it looked at is the people that had heart disease given fish oil, a very small dose, and people weren't. And they decided that there was no difference. Well, this is analogous to taking a bunch of rusty cars and getting paint and painting over the rust. And then a month later, the paint breaks down and they go, the paint's no good. And that's exactly what this was like, because they gave fish oil to people that had heart disease instead of looking at it prophylactically. But the real caveat is the author is the editor of the European Pharmacology Journal, and he's paid for by all the pharmaceutical companies that want you to spend money to buy medication and not natural products. So the fish oil has EPA and DHA. If your children or your children's children are on infant formula, there's DHA for brain development. It's probably one of the 2 best nutraceuticals you can take. It helps depression, it helps memory loss, it helps prevent memory loss, and the EPA is a natural anti-inflammatory that's wonderful for osteoarthritis, rheumatoids, and lupus. It also keeps your platelets less sticky. You have a lower chance of a heart attack, arrhythmia, and stroke. So the answer is yes. It's probably this. If you're going to take one insurance policy, it probably would be omega-3 fish oil. It's like buying high-test gasoline. If you went down the corner and you said, high-test gasoline is selling for 50 cents today, you know what? There's a good bet it's not high-test gasoline. And it's the same thing with fish oil. People come in with this big bottle of fish oil, and they say, I got this for $5, I got 1,000 pills. And if you open it up, it's of lower quality, it smells like fish. And there's a natural form and there's an ethyl ester form. The natural triglyceride form is actually a more natural form, and it will say it on the label. So it's not like drugs, they're not regulated, so anybody can come out with a product. So the higher end products are usually triglyceride form, and they follow good manufacturing processes, and that's on the label. And unlike medicines, omega-3s, the more you take, the better. Most medicines, the more you take, the higher the side effects. So it's one of those things that the more you take, the better. The problem is the labels are usually misleading. You have to do the math. People will come in and I'll say, how much fish oil are you taking? I'll say, I'm taking 2,000 milligrams a day because each pill is 1,000 milligrams. There is no pill in the United States that's 1,000 milligrams. If you turn it around, you have to do the math. You have to add up EPA and DHA. Most pills in this country are between 300 and 500 milligrams. So really, you have to take 6 or 8 pills a day, or the liquid, which is a teaspoon a day to get the proper amount. So most people are taking a very low amount, mostly because of the misinformation on the label.
It says here in your ad, outpatient knee replacement.
Yes.
You mean I'm going to go in and come out the same day?
Hopefully. No, let me qualify that.
You're going to replace my whole knee?
So let me qualify that. There's so much misunderstanding out there. There actually are some facilities in the country that are playing with outpatient knee replacement surgery. I've done outpatient partial knee replacement my whole career. Almost never do we keep a partial knee replacement in overnight. The biggest misinformation is a knee replacement. It's a bad word. We no longer replace the knee. We resurface the knee. So it's just a matter of whether we're resurfacing part of the knee, the kneecap, the medial compartment, or the lateral compartment. Or on this model, In the old days, we used to take a lot more bone off, but our modern knee replacement should be called a knee resurfacing, where all we're doing is putting a crown on a tooth, just like this. And this replaces the meniscus. But you know what? Your knee stays in there, all your bones and ligaments. We just reconstitute the space, we reproduce the cushion, and we put a crown on the end of the femur. This is what I call a complete knee replacement, considered a complete knee resurfacing, considered the modern knee replacement. If we only do half of that procedure, it's called a uni-compartment resurfacing. And then we do it as an outpatient. We numb up your leg, it takes us less than an hour, you're home in 4 hours. So yes, our partial knee replacements are all done as an outpatient. Our complete knee resurfacings, you're in the hospital 24 hours for 20% of the people. The other 80% are in the hospital for 48 hours.
Doctor, when you're doing your surgeries remote from your Allentown site, is it your team that goes with you?
So it's a great question. So our frustration was going into the garage, not knowing who the anesthesia folks were and who the rest of the team was. But medicine is local. And we travel to some rural hospitals just to bring care to those patients. I could not do it without our team. So essentially, we're reproducing 98% of everything we do at our coordinated health hospital. So we bring our whole team, and literally, I could operate tomorrow at any hospital in Wilkes-Barre, Scranton, or Tunkhannock, and I can do any one of our complicated sports or knee replacement procedures. It won't take us 1 minute longer than we do it in Allentown because my team is there. We also have a reconnaissance team, so I would not show up tomorrow, but my team would be there yesterday. They'd be educating the OR, and the best thing they could do is just watch and learn. That's why Marie comes, and they stay out of our way. We make sure that we have the correct anesthesia team, but I have all the confidence in the world. I've operated on my family members at some rural hospitals, and I wouldn't operate on any of my patients that I wouldn't operate on my family members. So we could take our team on the road and reproduce our product.
And the second question is the 30-year knee. Everything I've heard is that knees are good for about 15.
It's a great question. Do knees last 30 years? We'll answer that after this break. We're back with the question, do knees last 30 years? Let me tell you where that came from. This is direct-to-consumer marketing. So people come in and they say, gee, who wouldn't want the 30-year knee? And I said, well, why do you want that? And they said, I just saw it on TV. I said, well, when did that come out? They said, last week. I go, how do you know it lasts 30 years? And and it really doesn't. It's a gimmick. The standard in our industry is to simulate years by repetitions on one of these robotic machines. So they put it in the lab and they reproduce so many repetitions of wear on a total knee back and forth. And the standard was 20 years. So everybody measured it up to a 20-year simulation. Everybody wears tires different. If you got a set of tires and Mike got a set of tires, yours would last 5 times as long because I know how he drives. And the knees are the same thing. So in reality, when the other companies out there said, okay, we'll put our knee on the 30-year simulator, the 30-year knee actually did not perform as well as some of the other companies. So in reality, that's a fallacy just to sell knees and have you come in and ask the question. But if you really look to answer the question, how long do knees last? They're measured by survival rate, a statistical measurement. So after 20 years, what's the survival rate? How many of these knees are still functioning at 20 years? And most of the modern implants after 20 years will have a 90% survival rate. So that means if you get the knee, at 50, at 70, it doesn't wear out. You have a 90% chance that it's still in and functioning. And most of the modern modular knees have a polyethylene bearing that we can actually replace. It's not the metal that wears, it's the polyethylene. So we can actually replace that in a less than a 10-minute procedure. So that's the value that's pushed this operation down into the 40 and 50-year-old age group. What used to be you're too young, wait till you're 60. Now we're doing it in 40 and 50-year-olds. I've done it as young as 22.
Is there a female knee?
So that's a great question. Is there a female knee? The only problem with that is it takes me longer than 15 seconds to answer that, but that's going to be the first question that we answer in our next show. Folks, thanks for coming. I hope you've learned something. It was a lot of fun. You've met my high-performance team. Don't miss our next show when we'll answer that question about the female knee.